Welcome, everybody. We might have a few people still joining, but I'd like us to kick off in a timely fashion because we've got lots to get through today. So you're very welcome. Today, I'm Saffron Caudry and I'm Interim Chief Executive at NHS Providers. And today we're going to be looking at building on the insights from Core20PLUS5. And before we get into the substance, I just want to tell you a little bit about NHS Providers and the programme that we are running, and then a bit about Core20PLUS5. So NHS Providers, as I'm sure most of you know, is the membership organisation for trusts and foundation trusts, supports trusts to deliver high quality patient-focused care by enabling them to learn from each other, acting as their public voice and helping to shape the system in which they, we, and you operate. This programme, the Health Inequalities programme, aims to support members to make sense of health inequalities and embed it as a part of core business in everything that you do, with resources which is informed by our own research and engagement with trust leaders over the past year. So we've really looked hard into what trust leaders want and need from the health inequalities agenda, and then shaped our materials accordingly. Core20PLUS5, as I'm sure lots of you know, is an approach to tackling health inequalities, which looks at action on health inequalities for the core 20. That's the 20% most deprived in the population, alongside inclusion health groups agreed by trusts and ICSs, according to what's going on in their local populations, including ethnic minorities, the LGBTQ community, homeless populations, and people with learning disabilities and people with autism. And then the approach helps them prioritise 5 key clinical areas, including things such as cancer diagnosis, maternity, hypertension, case finding and management, and also severe mental illness and chronic respiratory disease. And what Core20PLUS5 does is offers a framework for trusts to identify where they can look deeper into health inequalities for their local populations, and also looks at how they can do that, particularly where they can't provide Core20PLUS5 cannot provide all of the insights that trusts need. So what they need to be able to do is also to assess their own needs and work out how they support others to access services and experience good care and outcomes. So this webinar is the first webinar in the series that we are running, and it's going to explore how trusts and their system partners can make best use of the data they've got from Core20PLUS5 approach by making sure it's supported by a holistic, embracing, qualitative approach to understanding the where, why, and how health inequalities arise. And this means understanding the wider determinants of health so that efforts to narrow the gaps in inequalities, access and outcomes are responsive to the challenges that communities face in accessing care. As you will have already heard, today's session will be recorded, so please make sure your microphones are muted during the presentations, and we will have a dedicated Q&A at the end of the agenda after all of the presentations are complete. If you've got points of clarification you want to ask the speakers, please hold them until the end of their individual sessions, but please make sure they're factual clarifications, or alternatively put them in the chat. Our speakers today, and we're really delighted they can join us, are Mary Hill, who is Head of Healthcare Inequalities Policy at NHS England, Christine Camacho, Public Health Registrar for the Office for Health Improvement and Disparities, and Merron Simpson, who's Chief Executive at the Health Creation Alliance. If you do want to ask a question or come into the conversation, please use the raised hand function, which can be found at the bottom of your screen if you're not familiar with Zoom. The chat function should be used throughout to add comments and questions, and we'll bring them out in the conversation. And Actually, if you ask a question in the chat and we don't answer it, then we will take it away and make sure you get an answer after the event. So I'm going to ask Mary Hill, Head of Policy on Health Inequalities at NHS England, to speak first. She'll speak for around 10 minutes, and then we'll move on to the other speakers. So over to you, Mary. Thank you very much.
Brilliant. Thanks, Saffron. Hi, everybody. My name is Mary Hill. I'm Head of Policy for Healthcare Inequalities Improvement at NHS England, and it's great to see so many of you here today. Really looking forward to the conversation and also hearing from the other panelists. So I'm going to attempt to share my screen. So wonderful, sharing the screen. So what I intend to do is give you a bit of a flavour of our National Healthcare Inequalities Improvement Programme, which will really help set the kind of context of the Core20+5 approach, give you a little bit of context around the development of the Core20+5, give you an overview of our infographic and some of the recent changes we've made to the approach, and give you a couple of updates, and then outline some of our wider support offers that go into kind of supporting delivery of the approach for all of you out there in the system and working in trusts. And then I've got a few questions that you might want to consider when you're thinking about engaging with people and communities on the Core20+5 approach and really making those links. So this slide here really sets out our kind of programme vision on a page in terms of what we're trying to do. So we're quite a relatively new team. We were kind of established last year, and a lot of us came into post over the course of the summer, but we're very much focused on delivering the NHS constitutional promise of delivering services for all, and also still continuing our focus on the NHS long-term plan around really hardwiring health inequalities into all that we do across all our national programmes, right throughout to service delivery, and really making sure health inequalities are at the forefront of all of our services. We're also very much contributing towards the government's vision around narrowing the healthy life expectancy gap by 5 years by 2035, which is an ambitious goal, and that's been set out in the Levelling Up white paper, which is kind of come back into focus again in recent weeks in this political environment that we're operating in. We are, our vision is very much around exceptional quality healthcare for all. We're focused on access, experience and outcomes. And then our programme, we've got 5 key strategic priorities for delivery. So we're focused on inclusive recovery, mitigating against digital exclusion, and we're developing a digital exclusion framework. Ensuring data sets are complete and timely, so a big focus there on ethnicity coding so that we can really understand where our health inequalities lie. Accelerating preventative programmes, and this is very much where the Core20+5 approach sits. And then strengthening leadership and accountability, and this is absolutely crucial around our kind of cultural shift to really drive change in health inequalities and narrow the gap. We've got a framework for delivery, which is the Core20+5 approach, and then we've got a number of strategic drivers out there in the system, including, for example, the Health and Care Act 2022, which has really strengthened our hand in terms of addressing health inequalities, thinking about giving regard to health inequalities in our plans, our decision making, and in our data collection and review as well. So that's really beneficial. So I did want to just flag very briefly the wider determinants of health, and it may well be that our public health registrar colleague talks about this in more detail as well. But really just wanted to flag the kind of the wider context. We recognise that the wider determinants of health, or the social determinants of health, make up 60 to 80% of our health outcomes, and the health inequalities are very much underpinned by the conditions in which we're born, grow, live, work and age. And you can see there on that kind of onion diagram that many of you will be familiar with, that healthcare services makes up a small part of that kind of complex relationship around health outcomes. But as a national team, we are very much focused on those health outcomes and what the role that we can be playing in the health service around narrowing that health inequalities gap. We've obviously got a role in terms of working in partnership and our role as an anchor institution and the opportunities there about how we employ people. But our Core20+5 approach is very much focused on those healthcare interventions where we can have an impact on premature mortality amenable to healthcare. So the next slide goes into a little bit more detail about some of our rationale around why we focus on the 5 clinical interventions in the Core20PLUS5 approach. So some of our research last year was very much looking at the global burden of disease data, and we were looking at premature mortality, where we thought we can have some of the biggest impact in terms of our clinical interventions. So this slide shows some very recent data, provisional data from 2020 to 2021, and you can see on the scarf chart there the kind of this social gradient in the life expectancy gap between the most and least deprived quintiles of England and the different causes of death. So you've got a portion there at the top that's linked to COVID-19, then you've got circulatory diseases, you've got cancer, respiratory, and many of you will be familiar with some of this gap as well. But it's really quite stark there, the data that around premature mortality. And the example we've shown there as well is around, specifically there around chronic respiratory disease. We know that exacerbations of COPD are causing admissions and readmissions to hospital, particularly over the winter months. So we're very much focused on that kind of link between deprivation and admissions to hospital, and the fact that actually a lot of these health inequalities are impacting on our operational pressures across the system. So this is why we've got a very much a laser beam focus on some of these clinical interventions where we think we can have an impact. So we developed the Core20PLUS5 approach very much to give you a place to start with addressing health inequalities. It's so huge. People are really struggling with where do they focus. You know, we're delivering our services. There's a lot going on out there in people's lives, in their communities, cost of living. What can we do in healthcare? So this is very much to give you a place to start, to really focus and look at where we can have an impact, really. So we did a lot of engagement on this over the course of last year. We had a survey, we had lots of focus groups, had lots of feedback from the survey, and refined our approach based on some of that feedback. So this is our latest infographic on the Core20PLUS5 approach. Now, Saffron kind of mentioned there the kind of population focus. So the Core20 and the Plus is very much the population groups. We've selected the most deprived 20% of the national population by the Index of Multiple Deprivation, which looks at 7 domains, and of which healthcare is one. We've chosen this as a national measure to avoid exacerbating any inequalities either between trusts, systems, or regions. And then the plus groups allows you that local level flexibility to really focus on some of your local populations that have poorer than average access to our services. So that might also include, Saffron gave some examples, but it could also include a coastal community or a rural community that really struggle with some of that access. But it incorporates a number of different groups and provides that flexibility to narrow health inequalities in your local trust or in your local area. We've got the 5 clinical interventions there. And we've been working on indicators, but I think it is worthwhile flagging that we have removed the target there on the midwifery continuity of care, and a letter went out to systems back in September, I believe it was, and this is in line with the Ockenden review recommendations. But we do know that this is an evidence-based intervention and has a real impact for women from Black, Asian and minority ethnic communities, and those also from the most deprived groups as well. So we have agreed to maintain midwifery continuity of carer within the Core20PLUS5 approach. We've got annual health checks for those with severe mental illness. We've got chronic respiratory disease. We're specifically focused on uptake of vaccines, so particularly COVID and flu vaccines, looking at early cancer diagnosis, hypertension case finding, and we recently expanded this out to include optimal management and lipid optimal management. And you can see across the board there, we've also added smoking cessation, because we know the impact that this can have across all of those clinical areas for some of these Core20+ groups. I did want to mention as well that some of the feedback was around children and young people. So we've been working really closely with our children and young people's transformation team and have agreed a Core20+5 approach for children and young people. So we are going to be doing some engagement on that in the next few weeks, and sharing an infographic around the approach for children and young people. So if you are from a trust that has a focus on children, young people and their families, then do look out for that. And we will be having a webinar in December time to really publicise this and focus on that. There is some support around the Core20PLUS5 approach. We've got our Connectors programme, which other panellists are also involved in. We're working with Health Creation Alliance, National Voices, Health Watch England, and this is very much around engaging people and communities from those Core20 plus population groups around sharing some of those key healthcare messages, but also allowing those communities to really engage with us and have access to decision makers around some of our services and how they work with our underserved communities. We've got an ambassadors programme whereby we will have ambassadors in every system. So there will be somebody from your system, either a clinician or a professional working across the system, and we'll be sharing some of our key messages, evidence-based interventions, etc., to kind of really spread the message and word around what works. We've also got a collaborative. This is we've got expressions of interest open at the moment, so we're going to be having accelerator sites, one in each NHS region, and the accelerator sites will be working with the IHI, which is the Institute for Health Improvement, testing some of those QI approaches around what works for health inequalities as well. So there's quite a lot happening. We've got other tools and resources, so we've got some key lines of inquiry as part of a leadership framework in line with the CQC well-led framework, and that's on the NHS Confederation website, but some really good key lines of inquiry there. We've got some education and training modules, so for example on health inequalities more broadly, and sickle cell disease, and we've got one on inclusion health as well. This is with Health Education England and Royal College of GPs, but I think some of those modules are really relevant. And we've got a health inequalities improvement dashboard as well, which I'll come on to shortly. We're also working with academic health science networks to test innovations, particularly for the Core20PLUS5 approach, and we've got funding for every system to do that, testing digital products, devices, diagnostics and medicines. So we've had bids come in and we're shortlisting at the moment as to kind of where that funding will go. We've got a health inequalities improvement dashboard, which is bringing together indicators in one place around health inequalities, and there's different. We've got lots of information on our website where you can click on and work out how to kind of get onto the dashboard and test some of that data. Some really interesting information on there as well around costs. Apologies, should have turned my phone off before. That's a rookie error, isn't it? But yeah, lots of information on that around costs of health inequalities and strategic indicators. So do take a look at that. It's really about very much triangulating the data with the data that you have locally. And there's some really interesting examples of what people are doing that from a trust out there, from a trust perspective. So one example would be Leicester, Leicestershire and Rutland, ICS and University Hospitals Leicester have been looking at their respiratory pathways. They've been in line with the Core20PLUS5 approach. They've been looking at their data. They've been looking at those, the DNAs, the do not attends, and they've discovered that actually it's the most deprived populations and some of their ethnic minority communities who are more likely not to attend. So as a result of this, they've been kind of making phone calls out to the patients on the list who they thought might be at risk of not attending, and they've offered kind of support around travel costs, access, thinking about longer appointments, and have shown a real impact there in terms of outcomes around reductions in DNAs. So there's lots of different thinking and different approaches that people are taking around that Core20PLUS5 approach. And then I'm mindful of the time, but we've got a few questions there around really thinking about how you're working with your people and communities on your approaches to address health inequalities. How do you engage with people? What is the nature of deprivation for your local populations and communities? Why is that important in terms of access? What are those practical challenges that your patients are facing in accessing your services, and how will this impact on delivery of your services and outcomes? But I'll pause there because I am mindful of the time, so it was a whistle-stop tour, and I will try to answer any questions that kind of come up in the chat box or later on.
Thank you so much, Mary. That's really, really helpful. There are some questions that have come up. I think that we may have to go back to people directly because they're mainly about presentations and links. There's one about the graph, but perhaps we can send a separate email on that. So I'm going to go straight on to our next speaker now so that we've got plenty of time at the end or as much time as possible at the end for questions. So I'm going to go now to Christine Camacho, who is Public Health Registrar at OHID. Over to you, Christine.
Thank you. Can you see my slides and hear me okay?
Yes.
Yeah, just wanted to check. Okay, perfect. Thank you. So I'm just going to talk a little bit about Core20PLUS5 from an ambulance perspective and some of our journey and context around that. So I'll focus on, I'll give you a bit of background and then pick out each of those dimensions and talk a little bit about that, and then share some reflections at the end. So in terms of some of the context about why this is important for ambulance trusts, so we see a huge volume of activity really at different levels of need. We're regional providers, and the data that we have in the ambulance services is really rich as well. That place-based data on incidents that often isn't available elsewhere. Already have established relationships with lots of other organisations and really act as both the gateway and the safety net for the health and social care system. And just to give you a little bit of the national context, so last year, the discussion paper was published around public health approaches within the ambulance sector. And we held a roundtable event as well, focused on health inequalities. And leading on from that, we're now developing a new national consensus statement on the role of ambulance trusts in addressing health inequalities, which is due to be published later this year. And just to give you a bit more context around that activity, so as a trust across the 999 service, NHS 111, and also the patient transport service, you're looking at an annual activity in excess of 4 million patient contacts. So it really is a large volume of activity. And just to give a bit of context, so we have a public health plan within the organisation focused on strategy, data intelligence, capability and supporting delivery. And we've included elements of Core20PLUS5 in that. So developing an action plan and trying to understand where we're at in terms of some of those clinical areas in a bit more detail. And I'll talk more in a bit about some of the work that's already happened. So following on from what Mary's just said, we've talked about inequalities in health. This is how we've kind of tried to frame it within the organisation. So to recognise that healthcare is and can be a driver of those health inequalities, but also that those wider social determinants are also very important. So we've kind of put the Core20PLUS5 framework sits under those healthcare inequalities, but there's also wider considerations in terms of those social determinants. So also thinking about the role of trust as an anchor institution and our work with a wider system in terms of kind of upstream prevention. And I won't dwell on this, but this is just really briefly just to show you some of the thinking around, again, the trust as an anchor institution and thinking about some of those wider determinants. So in terms of Core20, sorry, this isn't the most updated one with the smoking cessation on, but starting from this, the basic framework, I'll just talk you through our kind of interpretation on this and some of the work that we've done on this. So in relation to the Core20, so the Northwest region has high levels of deprivation. So actually for us, that's pretty much a Core33, not a Core20. Because nearly a third of our population live in the most deprived quintile. And deprivation matters and it is important. So this was a slide that we actually took to our trust board when we did a board development session. And the trust had never actually had the activity data broken down by deprivation in this way. And this was just a 3 months worth of 999 data. But what it shows here is that the people living in the most deprived quintile have nearly double the rate of 999 incidents to those living in the least deprived quintile. So deprivation is an important driver for demand, but it isn't explicitly taken into account in ambulance service funding. And if the Northwest had the same deprivation profile as England, so 20% in each quintile, that would equate to approximately 85,000 fewer incidents a year. Okay, so thinking about the plus groups now, these are some of the ones that we've identified. And if I tell you now that from the year that we looked at this data, the average life expectancy for men was 83 and for women was 86. So while I'm talking through this slide, please feel free to put in the chat what you think the average life expectancy was for people experiencing homelessness. Okay, so I'll have a few answers to that while I talk about some of these groups. So for high intensity users, I'm going to come on to talk about that in a little bit more detail, because this is a group that we've identified certainly for ambulance services as an important plus group. For alcohol and substance misuse, there was an analysis of data from another ambulance trust that estimated that 10% of call outs were alcohol related, and some modelling to say that nationally there's 350,000 alcohol related call outs per year at a cost of over £80 million. So I think this is an important group for us, but actually we can't identify from our data at present any alcohol related incidents. It isn't something that's coded. In terms of learning disability and autism, NWAS have recently developed a new strategy around this. And I can't actually see the chat, so if anyone's put anything in there, I should have checked that before. I can't actually see that, but I'll tell you that for homelessness,
people have put in there ranging from sort of 38 years, 45, 47, 48.
Okay, yeah, so it's 44 years is the median age at death for people experiencing homelessness, which I hope is something that we're all kind of shocked by. That was the average male life expectancy in 1888. And we think this is a group of people who have different patterns of health use and probably do use ambulance services more. But again, we don't actually have any systematic way of identifying this group of people. So we're still very much on a journey, even though we've kind of identified these as our plus groups. I'll just say a little bit more about high intensity users. So there's a really good report from the British Red Cross, which is focused on A&E, high intensity users. And you can see there a very small group of people, but with a very heavy service use. Within NWAS, high intensity users for 999 are people who call 5 or more times in a 7-day period. And again, we've looked at that by deprivation quintile and found that the rate of high intensity users was 3 times higher in the most deprived quintile compared to the least deprived quintile. And we really come to the same conclusion that the British Red Cross did in their report, that high intensity service use is a health inequalities issue. So these were our thinking around the clinical areas. So I'm told by our medical director that our trust delivers the same number of babies as a small district general hospital. We have a very high volume of calls around mental health incidents and exploring some of those links around supporting health checks for that group of people. Breathing problems is one of the top presenting complaints, so thinking about whether there's any possibility of extending home oximetry through our 111 service. It may be something that we could look at in terms of those red flags for early cancer diagnosis. And I'm going to talk in just a little bit more detail now around hypertension case finding. So in the Northwest, there's an estimated 500,000 people with undiagnosed hypertension, and we know that that is also varies by deprivation and is an important factor for other illnesses. And every person with a face-to-face contact will have their blood pressure taken. So we actually take blood pressure readings from over 1 million people a year. So we did a small pilot with just one primary care network to see whether we could try and use that data to identify people with undiagnosed or unmanaged hypertension. And this is the results of that pilot. So overall, 40% of people did receive an intervention in primary care. There were new diagnoses or changed their medication. And the PCN kind of valued that data and said that they wouldn't have access to it otherwise. So this just brings that all together in terms of how we've actually kind of modified or adapted, if you like, the Core20PLUS5 for this organisation. And just really quickly, a few reflections on this. So this really represents a longer journey for the trust in terms of thinking of itself as a public health organisation. That's still in progress, and we're just at the point of actually establishing a public health team within the organisation. But I wouldn't say that this is yet core business. I'd say that that's still a work in progress. But a really good starting point for us was actually understanding our own data, and we did experience a lot of data quality challenges with that. So Mary mentioned ethnicity data. Whenever we've tried to look at that, unfortunately, we haven't been able to use the ethnicity data we collect in the organisation because the data quality just isn't good enough. And my view is that Core20PLUS5 is a framework that we should kind of adapt it to meet the needs of the population that you're thinking about. And that although we can say that health inequalities is everyone's responsibility, unless it's actually someone's job to do it, it's not likely to happen. So thinking of that in terms of organisational governance and staffing as well. And the emerging themes on the bottom there is just a bit of a headline on some of the work that's coming out of the National Consensus Statement development that I mentioned. These are some of the areas that we think Ambulance Trust, and I'm sure that will be true of other organisations as well, require support with in terms of embedding these approaches and tackling health inequalities. Okay, so I will stop there. I'm happy to have a look at the stuff in the chat if there's anything and try and put some responses to that in.
Thank you so much, Christine. That was fascinating. And our final speaker before we have a bit of discussion, if there's time, is Merron Simpson, and she's going to talk to us about health creation approaches and Core20PLUS5. So over to you, Merron.
Thank you very much, Saffron, and thanks to Christine and Mary as well before. I just by way of sort of introduction, Mary sort of said right at the very end of her piece how you're working with people and communities to do this, and that's the part that I'll be focusing on. So my name's Merron Simpson. I'm the only speaker today who's from an independent organisation, i.e. not a government body, and my colleague Donna McLaughlin, who's the Director of Social Value at the Northern Care Alliance and the Director at the Health Creation Alliance, couldn't be here today, but I'm going to include a case study from her. So hopefully that will you'll get a little bit of her. I'll just say a few words about the Health Creation Alliance first, because you may well not have heard of us or know much about us. What is health creation as well? A little bit about the work we're doing with Core20PLUS5 on the Connector programme in particular, put in a case study and some of the insights that are coming out of that Core20PLUS5, plus a case study from the Northern Care Alliance, and then just a few other bits and pieces at the end. So hopefully we'll be able to get through all of that. I'll just share my screen, and please just give me the thumbs up if you've got that. Is that okay? So. Right, great. So the Health Creation Alliance is the leading national cross-sector movement addressing health inequalities through health creation. And we're a mix of professionals from many sectors, community leaders, and people with lived experience of poverty, trauma, and discrimination. So we're a real mix. And we're a movement. So our mission is to increase the numbers of years people live in good health in every community, including those in the Core20PLUS5 categories. And our ambition is for health creation to become business as usual across all systems and recognised as equally important in addressing health inequalities as the treatment of illness and prevention of ill health. And we do a range of activities to support this. So I'm not going to talk through all of these, but our method, we have a sort of movement and a method, and our method is around the connecting of people together to learn together and to transform together. So that's how the transformation happens, through the relationships and communities of learning. So but we focus on what matters from the lived experience perspective. So we're very much about the community perspective, but we are a lot of professionals working as well together on this. And we leverage change across systems, working with our members and partners. And I think that's an important part to bring out. And we do work locally if when asked, as well as nationally. So a little bit about health creation. Health creation, then, how we define it, is the process through which individuals and communities gain a sense of purpose, hope, mastery and control over their own lives and immediate environment. And when this happens, their health and well-being is enhanced. And so we're looking not so much at what causes inequality, but what actually causes health. What are the causes of health, and what are the solutions, therefore, or what is part of the solution? So essentially, we have the 3 C's of health creation: connections or contact, building meaningful and constructive connections between people and with communities increases their confidence, and that leads to greater control over their lives and the determinants of their health. Very simple, but there's a lot of evidence now for this, and we're doing a project at the moment with NHS England on updating a lot of evidence that we've brought together, and there's even more. So of course, people, that control is all important in many ways, including in access to the wider determinants of health. So people need also an adequate income, a suitable home, an engaging occupation, and a meaningful future. You'll recognise some of the wider determinants in there. Of course, having agency, it doesn't automatically mean you can get access to those, and there are structural inequalities as well that also need to be addressed, but the agency and the control helps with that. So having control over lives and environments is proven to enhance health and well-being and to help people cope well with health conditions, disability and aging. So it builds resilience, essentially. And the way that we also talk about it is that professionals can do things, communities can create health on their own and do all the time, because they're building those connections that create confidence, that help people to take control. But actually, professionals can also help to create the conditions for health creation to take place by working as equal partners with people and focusing on what matters to them and to their communities. And we've identified these 6 features of health creating practices that we would like all professionals everywhere to build into what they're doing, because this is what people whose health has improved through a variety of means, this is what they say makes the biggest difference. So this is what communities whose health has improved say makes the biggest difference, and they are listening and responding. So listening to communities and responding to what they say. Truth telling, which is the foundation for trust building, as is listening. Strength focus, so focusing on what communities can do, not their deficits. Self-organising, so recognising that community networks exist and working with them, or helping people to connect for a purpose and to take action. Reciprocity comes next. It was the last one that we added, but it kept bubbling up to the surface. And this is about understanding that for communities, the give-get relationship is really important. There's a reason why the Wigan deal is called the deal, if you've heard of that, because there's a reciprocity within it. And all of that helps to shift power, but that power shifting does need to happen. The locus of control here needs to shift to the community. And we've been doing this for about 7 years now. This is our manifesto for health creation, published in 2017. So that's enough about health creation, but just to say that, just to give it some validity, Marmot's 6 policy objectives, 3 of them relate to this. So particularly the last one, create and develop healthy and sustainable places and communities, but also enable all children, young people and adults to maximise their capability and have control over their lives. And involved in that, is a fair employment, etc. So it's very much what Marmot talks about, and there's other slides I could have put here to demonstrate that. And what we're saying is that if you embed these things into what you do, this 3 C's and the 6 features, it can actually enable many, not just enable, but it enables you to do all these things really well. So it's relevant for Core20+5. 5 health inequalities priorities that Mary mentioned earlier. We did a piece of work to demonstrate, and we have a publication to demonstrate how health creation helps can help you to meet those 5 health inequalities or achieve those 5 health inequality priorities. But all of these things, population health management, etc., and the ones in mustard in between are from one system and what they are looking for in their health and wellbeing strategy. So community-led action is all part of this. So what we're trying to do is essentially change systems from the ground up. It's those relationships within the community and between the community and the front line that if we can get the dynamics of those right using that 3 C's and 6 features, then we can shift, then that can drive change across the system, and we're seeing this starting to happen now. So Core20+5, we are working with SCW, that's NHS South Central West, and on the NHS England programme for community connectors with National Voices and Health Watch. And the element that we have focused on here is the dynamic in the relationships between the connectors and the services or the systems. And so I'll just give you a few insights from a workshop that we ran with both connectors. It was pre this programme actually establishing, so it was informal connectors and formal connectors both together. And what we found works in the connector roles in terms of working with communities is that having local knowledge, being embedded in communities and knowing the community is important. So somehow the systems need to build the infrastructure to be able to go and understand communities and listen to them, have the right conversations with communities, then you'll know how they think and understand their health needs, because the qualitative data that you get from that, the community insight, is at least as important as that quantitative data that you get through your dashboards. In fact, I heard just the other day from someone that when it comes to some of the things like homelessness, it's qualitative data very much trumps quantitative data, because you just can't get the quantitative data on it. So you need to gain that community insight. Focus on what people can do, the assets, we've already talked about that, linking people together so they can create collective action, the power of self-organised communities where people are connected to each other and taking action together cannot be underestimated here. That has to be the goal, actually, to enable communities and people to take control. Longevity of the role, not just a programme and then we go home after 3 years, being there for the long term, because communities have been let down a lot, and that's where some of the trust deficit is. So not dipping in and out. And also these connectors do need to have the ear of the people with power in the system. So that's where the dynamic needs to be worked on between the system and the connectors. And a few things here that should be avoided. I'm not going to go into all of them, you can read them quickly, but parachuting people in who don't know the community and how it works is a real no-no. And expecting behaviour change. Stopping smoking isn't always the biggest thing in someone's mind, actually, when they're living in certain circumstances. They might be worried about and actually quite ill with very many stresses and chronic stress. So the focus on behaviour change can be quite unhelpful. But I won't go through all the rest of these, but there are some things that should be avoided. I'm happy to share these slides. So just going on to another sort of, this isn't actually from the work we're doing on Core20+5, but it is highly relevant, and it is about trusts, because this is the Northern Care Alliance that works across Bury, Rochdale, Salford and Oldham. And what they're trying to do in this programme is they have an ambition to employ 1,000 residents from underserved communities to enable them to progress in their lives by 2025. This is very health creating work, and Donna is working on this with had been working on this with a community researcher called Chris Dabbs from Unlimited Potential. So we published this in July, and you can find it on our website. But how can NHS anchors support communities to create health? We have another case study in here as well, incidentally, but I'll focus on this one today. So essentially, NCA has 18,500 employees, and they started asking the question, what is the potential to improve health outcomes in some of these areas? They started with an area called Coldhurst, where the hospital is situated. And this was the lowest scoring for adult skills in the index for multiple deprivation, which we'd prefer people to call the index for multiple social injustice, by the way, but it is called the IMD at the moment. And so in that area, they did some work. The trust wasn't there. There was very few employees from the Coldhurst area, despite the hospital being there. They asked a community research group to do an employer attractiveness survey. They had to get a third party in because of the trust element. And this, it was unlimited potential. They worked through conversations. So this wasn't surveys or typical research. They very much went to the places where people hang out and just talk to them, just have conversations with them. And through that process, which took a number of weeks or months, they developed two sets of insights. One was insight into the barriers to work to getting a job with the hospital, the NHS Trust, the NCA. But actually, they came up with some solutions as well. So communities are full of ideas about how to make it better. More than ideas, actually, they really know how their communities tick, and they've got lots of solutions. If you can find them, if you can dig deep and find them. And when they got their research, the National Care Alliance responded. And they did so by developing pre-employment programs, not offering to communities, but with the community groups they'd started conversations with. So they started developing them with those groups, and those groups helped to recruit participants. They held those programs within the community venues. They carried on listening and responding, and the community said, look, we think there's racism here. What's the E&D policy? And what they did was they responded by offering them training on the exact training that the staff get at the NCA on their E&D, not just the policy, but the training as well. So that helped to build the trust, because they were being open about what it was that they were doing in relation to equalities and diversity. They offered guaranteed tailored 2-week work experience, and they changed their recruitment processes. So they weren't having these barriers, these hurdles to get over the GCSE barriers. So completing this pre-employment program became equivalent to having the minimum requirements of GCSE. And there was no need for a formal interview, which is very scary for people who, for some people. But they did that in a different way. And I need to catch up with Donna to see how they've got on with this, but I know that they've got many people coming into this scheme. And 3 weeks into this, another mosque came to the NCA to ask if they could work with them. So that's just one example of this. I know it's going well. Just to say, yesterday, the Health Foundation did a very good lecture with Andy Haldane, CEO of the RSA and former chief economist of the Bank of England. And it really scared me, actually, I know health and wealth is very interlinked and very creative, very much connected. But I would advise you to have a look at that. It will be on their website. But improvements in population health have been a major determinant of economic growth for over 100 years. But the increased sick rates are impacting on the economy now, and that's across many parts of demographics. But none of the economic growth over the last 15 years has been from increases in productivity, only from getting. There's two cylinders, and that's one of them, and none of them were from that. And the health is now a brake on economic growth for the first time in 100 years. Those are the headlines. Go and have a look at that. But I think that trusts have a significant amount to bring here in terms of wealth creation and health creation as a route to all of that. So these are the last little bits at the end. In addition, we've done, we did a series of events 2 weeks ago, and online events, mainly one face-to-face, called Health Creation Coming of Age, because we think that now is the moment that this is needs to be adopted across the system. And I would say actually, that it needs to be part of everyone's job, not give it to just some people. So I would probably want a conversation with Christine about that. Of course, there's roles within it as well, but I think everyone needs to understand and to some degree adopt health creation. But there's a number of things here, particularly number 7, creating health by supporting broader social economic development, but also health creation Core20PLUS5. We work on those clinical issues as well, and the recordings will be available online soon from all of these in maybe a couple of weeks' time. So you can get them from the Health Creation Alliance website. And here's a few reports we've done in the last 2 or 3 years. The reason I put this up is just to say one of them there is about earlier cancer diagnosis and improving cardiovascular diagnosis. So we've done a piece on health creating in relation to those 2 clinical areas. So it can be applied to clinical areas, but also creating spaces for community and patient wellbeing. We've just published this 2 weeks ago at the series of events with NHS Property Services, and we would love you to have a look at that and take some of that on board. So we've been doing this for 7 years nearly, and please do join the Health Creation Alliance for more information. Thank you very much.
Thank you so much, Merron. Well, we are very nearly out of time, but I am just going to see if I can sneak in a question or 2. And there was, I thought, a really interesting question given the importance of this agenda to trusts and kind of gaining traction is so important. I just wondered whether Christine, you would be able to answer the question that's in the chat about what were the key factors in getting board engagement with health inequalities other than good data? Because I think it's something that, every trust that's engaging in this wants to think of a way to get their board on side and fully engaged with this. So any thoughts on that?
Yeah, well, I don't think there's one simple answer. I think it's a combination of different factors. It took, I'd say, probably about 18 months to actually secure that board development slot. So it wasn't just a quick win. It was a combination of kind of building relationships in the organisation, doing some of that analysis of the data, but also looking at some of the policy levers around this. So the fact that there was a new CQC policy last year on inequalities, looking at the NHS Confederation, key lines of inquiry, all of these kind of wider drivers in the system that mean that, this is everybody's business and we can't ignore it. And I think in that point of trying to adapt the Core20PLUS5, it's thinking about what are the organisational hooks that are going to gain interest in that. So I think it's a combination of things. Sorry, I don't have like one pithy answer to that. But yeah, it's a few different factors. And to just address that point that Merron's just made about it is everybody's business. But I think my experience really was that it's something that within that trust had really struggled to get off the ground because it was difficult to identify whose job and whose responsibility it was to actually do the doing on some of that. And actually having some public health registrar support there meant that some of that work could actually be taken forwards. Because through the pandemic, when obviously the organisation was very, very busy, unfortunately I couldn't get out and drive in an ambulance. I'm no good for anything like that. I was able to continue working on this health inequalities agenda when everyone else was kind of pulled into operational work. So it's having a focus point. It's it was beneficial.
Thank you so much. And what really, I think we all know, don't we, that if there were one single solution or a kind of, a perfect equation that would help us solve this problem, then everyone would be adopting it and using it. A blueprint would be really helpful, but we know it's not like that. What I've been really struck by in the conversations, and it's just great to have you 3 together actually, because it's great to see Mary talking about the Core20PLUS5 framework, and then to have you, Christine, talking about how you're doing it actually in a trust and what it means to bring that to life on the front line, particularly an ambulance trust, actually, where we're dealing with everybody actually in the community. And then to have that perspective from Merron, which is about, the glue that that kind of community-based organisations can provide in making sure that then there's that further bridge into the community itself. So I think, you know, for me, that really helps to make sense of the, don't want to use the hierarchical sense of top to bottom, but sort of inside out and outside in terms of how it fits together. We've had a load of questions in the chat and a load of requests for further information. We're going to pass all of those up and make sure that people get access to what they need from that. I'm really sorry that we couldn't go into more Q&A, but your presentations, each of you, were really rich, and I didn't want to cut us off there because I think having that information out there is really important. Christine, did you just want to quickly come in?
Just one really quick point that I think is important that I forgot to say before, which is about strategy and governance. So the organisation was doing a strategy refresh, and we also use that opportunity to try and get health inequalities as strongly as possible into the new corporate strategy. And also having a public health delivery group embedded within the organisational governance to take forward that work. So they were two other key drivers, really.
Yeah, thank you. And that's, I think that issue about being opportunistic when something is coming up to then incorporate, and particularly a strategy refresh. We do have to draw to a close because I don't want us to overrun today. I do want to thank my speakers because they've given us such a really helpful insight, and I do want to thank everyone who put comments or questions or thoughts in the chat. We will be getting back to you all, and I'm sorry we couldn't have more of a Q&A today. We've got a peer learning forum coming up on quality improvement approaches to health inequalities, already fully booked, I'm afraid. So if you haven't booked on, you won't be able to join that, but that's coming up on Monday, the 5th of December. If you haven't already, please do sign up for our next webinar, which is on Wednesday, the 7th of December, which is about how we support staff to drive health inequalities improvement in services. And we'll send you that information after this event. We will give you an evaluation form. It's really important to us that as we develop this programme, we hear from you about how you found today's session, what you want from the future of our programme. So thank you so much, particularly our speakers, but everyone for participating. It's been lovely to see you, albeit virtually, today. And I hope you have a good rest of the week. Thank you.